Good morning, everyone. Today we will have Dr. Ravindran and Dr. Marenko presenting pituitary cases. So, Krishnan, do you want to start? We can wait a couple of more minutes, but if you want, you can start sharing your presentation.
Sure. 1 second. All right. Can you see the slides there?
Yeah, we can see the slides.
All right.
Yeah.
So this is a case done with JP and Dr. Q. This is a 49-year-old female who's from Ecuador who presented to us with recurrence of her known craniopharyngioma. She had a history of vision loss in September of 2020 and presented locally in Ecuador, where MR demonstrated a cellular lesion. She underwent a sublabial transfernodal resection of this lesion in September of that year in 2020. She remained relatively well vision-wise in the interim postoperative period, but noted some deterioration in her vision and worsening of headaches, as well as radiographic progression in February of 2021. And so a second resection was performed by a transcranial terional craniotomy, at this time also in Ecuador. Over the last 2 months or so, she noted worsening headaches again with increasing blurry vision, left greater than right side. And so she presented to Mayo Clinic for second opinion following evaluation in Ecuador, where radiosurgery was recommended. Notably, at that time, she did not actually undergo radiosurgery following either of the resections. Her past medical history was really unremarkable. She was relevant for some gynecological surgeries, and as we said, the prior sublabial transfernodal resections and the terional craniotomy. She was notably on prednisone 5 milligrams daily following the second surgery, but did not demonstrate any marked evidence of diabetes insipidus that she reports following either of her surgeries. She was an ex-smoker, smoked 10 cigarettes a day for a few years. On examination, when she presented to us, her cranial nerve examination was relevant for a complete bitemporal hemianopia. She's unclear, and we're unclear really what her visual field exam was. We don't have visual perimetry following her index presentation or her first surgery, but she reports this is worse than what she presented. She reported that this was worse than what she presented following the initial case. These are her endocrine lab values. Yulia, if you're able to provide some insight.
Yulia, we're not able to hear you.
You hear me now? Sorry.
Yes, that's okay.
Oh, okay. Good morning, everyone. Okay, in regards of her hypothalamic pituitary axis, when she presented to us, we see the cortisol was low, but she was actually on prednisone 5 milligram, which she was taking in the evening, and that's when her when we check her ASATH, which is like on, it's not super suppressed, but on the low side. But we're not sure if she was started prednisone or due to adrenal sufficiency or because her worsening of her vision. In regards to her thyroid, there is no signs of the secondary hypothyroidism at this point. Her prolactin was mildly elevated, which probably consistent with the stock effect. And in regards to her LH and FSH, which is suggestive of her, which is appropriately elevated, because her estradiol, which is indicates what she is in postmenopausal state at this point. I think in her sodium, she didn't have and express any signs of a DI after surgery or like any symptoms concerning a DI.
So just to add, good morning, everybody. JP Almeida here. I remember talking with her that in more than one occasion, she was referring to the use of prednisone as a therapeutic option for management of the visual decline. Although that I agree that was unclear to me, she kind of like reinforced more than once that was likely the indication. So we were initially facing a patient that, at least in theory, had quite preserved pituitary function here.
Agreed, JP.
She was seen by neuro-ophthalmology, which redemonstrated what was observed in exam, these visual field testing demonstrating complete bitemporal hemianopia. Dr. Eggenberger, if you had any more insight.
Looks like she's a pretty consistent field taker, and just as you stated, absolute bitemporals.
Thank you, sir. And
just as a reminder, Chris, did she have any prior ones? And I don't know if Eric remembers this.
At least what we know
she did.
At least that we know on history, this was a worsened visual field deficit compared to a presentation back in September of 2020 in Ecuador.
Because what she reported to me, Eric, and I don't know if she reported that to you, is that she had really bad vision deficits. She had the first intervention and she got markedly better. So I don't know if we had any evidence of those visual fields over time, how they were ranging or not, or if you have any recollection, Eric, of anything like that.
Yeah, I don't recall offhand if we had a chance to look at any of her prior eye records.
These also just reinforce the largely preserved pituitary function with the stock effect there that you see from the prolactin elevation. These labs are from March 15th of 2021. So she underwent an MRI with and without on January 4th of 2022. And the MRI, this is the T1 pre on the left, post contrast in the middle, and then the T2 on the right. This demonstrates a cystic lesion with largely only suprasellar extension and minimal lateral and really no cavernous extension. And you can see on the T2, let me go to the next slide, there's some better cuts there, that the pituitary gland is displaced inferiorly and the optic chiasm is displaced superiorly and posteriorly. Hard to appreciate maybe on these cuts, but on the other cuts on the T2, you can see also the A1s and the ACOM complex also displaced superiorly. What you also notice is this peripheral area of contrast enhancement abutting circumscribing the cyst as well. And if you go down here, you can see evidence of which I'll show on our CT sinuses in a few slides, but you can also see the evidence of the prior sphenoidotomy from her index surgery in Ecuador in September. Dr. Murray, did you have any additional comments?
No, excellently well described. There is some, if you went back, there's actually abnormal signal going along that left optic tract. You can't go quite, it's right there, you're splaying the chiasm, but as you go back, the left optic tract is actually mildly enlarged and has abnormal increased T2 signal. I would wonder if there was even a worse visual field defect on the right. Probably Wallerian degeneration going along the tract, could be edema also going along the tract. This is a classic appearance here for which is a more common, the adamantinomatous variety, which we typically see in younger patients, with which 90% will have this look of cystic with mixed cystic and little solid areas of enhancement. Often you'll see very bizarre cysts with increased T1 signal and decreased T2 signal because they get this inspissated proteinaceous fluid within them. But not much to add. That certainly the bitemporal makes a lot of sense looking at these images.
And Dr. Murray, can you maybe comment in the relationship you see in the axial and the coronal, a little contrast enhancing, which is obviously likely the tumor, but what is the relationship of that to the optic chiasm?
So the relationship, let me look on my end. I have it up.
Yeah, because that's something that was, you'll see what we found intraoperatively, but I underestimated the intimate relationship of that to the
That is
chiasm.
anterior. One
And
second, let me see.
Mhm.
Up 1 sec, and I'll tell you. I want to look at the cross references.
And I don't know if the T2 sagittals can tell you a little bit, just like the T1, in that case. You'll see what we found intraoperatively, and maybe you can comment as you're studying that, so we continue with the case and see if what you see imaging-wise matches what we saw intraoperative-wise. Does that sound reasonable, JP? Is that a good assessment of how we're going to look at this case?
Yeah, I just wanted to add a few comments. Can you see my mouse arrow right now or no? No? Uh, Well, it should be sharing here. I just wanted, maybe you can help me, Krishnan, here. Can you put your arrow right at the pituitary gland of the T1 post-sagittal? So just a few issues few features that I think are nice for assessment of pre-op craniopharyngioma. So the first thing is where it's located, and I think Chris described it very well. Basically, this one is pretty straightforward, suprasellar, so located right above the pituitary gland, and expanding, but located above the diaphragma. So if you see pituitary gland, it is located just like above the diaphragma and right posterior to the tuberculum sella. So first, that's the first thing. The second thing is the relationship with the pituitary stalk. So Krishna, if you can go with your arrow at the gland, and then you can follow the gland, the hyperintensity tissue, you can see that the stalk will continue located right behind the cyst itself. So it would be basically a preinfundibular craniopharyngioma in this case, so anterior to the stalk. The third aspect that additional to the optic chiasm that is important is also the relationship of this line between the mammillary bodies. So Krishna, if you can just cross a line from the pituitary gland, top of the gland, all the way to the mammillary bodies with your arrow. And then if you go all the way to the region of the pineal gland, so pituitary gland, all the way to the region of the pineal gland, and then crossing towards the floor of the fourth ventricle, we would see the relationship of the, I'm just gonna try this one more time here. Yeah, for some reason, I think you guys can see, but the relationship. So when the mammillary bodies are displaced downwards, it's suggestive of extension into the ventricle, into the third ventricle. When it's displaced upwards, it's suggestive of extension purely in the cisternal component. On this case, though, the cyst is not extending too much backwards. So my interpretation is that the lamina terminalis was mostly intact here, and then we would be able to get that component just in cisternal components. So I think let's move forward, and then as Dr. Q said, the surgical video will highlight some of those aspects.
Patient was seen by neurosurgery, neuroendocrinology, neuro-ophthalmology, and Dr. Trifoletti. Given the progressive visual decline and headache location and size of this lesion, though various management options were considered, surgery was recommended for this patient. Of note, the patient, as I said previously, had not undergone radiotherapy treatment following either resection in Ecuador. If the patient had decided to forego surgery, then either proton therapy or radiosurgery would have been recommended. Like I said, the patient had already had one sublabial transfernodal index surgery in September of 2020, followed by a second transcranial approach. This time, given the location and visual symptoms, the decision was made to resect this lesion via an endoscopic endonasal transtubercular approach, with plan for reconstruction of the sella with the fascial autograft and drainage of CSF diversion via 72 hours of lumbar drainage.
Just one point before Krishna will go on. So the reason for the endoscopic endonasal transtuberculum approach certainly was because of the relationship, the anatomical location of the cyst that was mostly in the suprasellar space. So the addition of a suprasellar approach, which is the transtuberculum or the removal of the prechiasmatic sulcus region, is what adds to the complexity here and high flow CSF leak, since we're going to be opening the cisterns. This case had additional a patient that had had 2 surgeries before, including one sublabial and a previous history of smoking. So we had to have concerns about the reconstruction, and therefore the lumbar drain, in our opinion, would facilitate the reconstruction as well as the fascia lata. Just to add a few additional points to the rationale here. And the Tiriono approach is always a useful approach for this suprasellar region as well. The one detail and one caveat is that you're going to see how beautiful exposure of the superior hypophyseal branches and no need for any brain manipulation the endoscopic and the nasal approach provides us. So I definitely believe it's the best approach for this case.
And then maybe JP and Chris, just go back and show where the carotids are in reference. So that way, because it's going to be contrast to the next case that we're going to show. So maybe point that out.
Perfect point, Dr. Q. In the sequence that we have here, we just have the supraclinoid carotids as Krishna is showing there. In this left side, in the T1 post-coronal, we can kind of see the most posterior part of the clinoidal segment of the carotid. So if you look, let's use that one. So if you look at the left carotid and you look at the right carotid on this side, you see that the spacing between those two vessels are quite significant, which helps us, of course, with this approach. So for suprasellar approaches, transtuberculum approaches, the one segment of the carotid we want to be paying attention to is the clinoid segment of the carotid, which is always the most anterior segment of the carotid in relation with the sagittal plane. So this provides us a good corridor for the resection, and Dr. Q said the next case will highlight why that's important. Please go ahead, Krishnan. Thanks, Dr. Q. Good point.
Sir, some of the risks with any endoscopic endonasal approach to the sella, risk of DI-CSF leak and olfaction, as we discussed. So this is outlined.
And maybe, Chris, the only one that you didn't mention, just go back to that, is I don't see the risk for meningitis, which it does happen, and it's very significant. And we have had a few issues already, you know, with that. So it's just very important to point that out.
Noted. Thank you, sir. So the patient was positioned supine in standard fashion. The approach was aided by the ENT team. I'll show on the CT sinuses the surgical evidence from the anatomic evidence of the prior endoscopic surgery. And like I said, the plan was to reconstruct the sella with a nasoseptal flap as well as harvested fascia lata. This is the patient's preoperative CT sinus, and you can see the generous sphenoidotomy that's already been done, but also you note that there's relatively poor pneumatization of the clival recess here, and you can see that a fair amount of cortical as well as cancellous bone is required to come transtubercular to get to the space where the craniopharyngioma is residing. And then you can see on the axials bone window on the far right, the septal deviation that also exists. JP, did you have anything else?
That sounds pretty good. Just one comment. Every time that I like looking at the sagittal and at the coronal. So you see that the cribriform plates, they tend to go deep if you look at the coronal scan here. So you can go right at the cribriform plate. This is also in highlight in comparison to the next case. But the plan in here, it's in the front, and you see the posterior ethmoidal cells in the sagittal plane that are quite significant. So in this case, we had a better angle of view than compared to the next case. And this is just so we can compare and remember this image with the next image. But you said very well, like we have to drill all this. We have to basically sculpture the sella in the suprasellar space.
I'd like to add that if you look at that CT scan, she had a septal perforation already that probably came from the prior sublabial approach to the skull base. And so that's very important for planning to see if the nasoseptal flap is still viable on that side. There's a big risk that the vascular supply to the nasoseptal flap has already been taken. So early in the case, we plan to Doppler the posterior septal branch of the sphenopolitan artery to verify that we have a flap. Also, because of the septal deviation that you can see in that coronal view, you know that the right side cannot be used. The mucosa will be very thin over that septal deviation, and we will not get a watertight flap. So with these two things, we know that fascial lata graft is mandatory in this case.
Thanks, sir. I'm just going to stop sharing this so I can go to the video for a sec.
I've reconstructed too to show that relationship on a 3D isotropic on the space if we want to look at it later. To look at that enhancing portion's relation to the chiasm, really kind of pretty.
All right, thank you. Share screen.
And now,
Place that was drained at initially 5 cc's per hour, then later raised to 10 cc's per hour on post-op day 1 until post-op day 3. Post-operatively, by post-op day 2, the patient's vision had in fact improved. And when I examined her just before she was discharged, her visual fields had improved to a left inferior quadrantenopia. So she had recovered some vision in the left superior temporal and the right superior temporal quadrants, both sides. This is her post-op imaging demonstrating some residual enhancement. As you can see, there's a bit of motion artifact, some residual of that enhancing capsule that was largely adherent and was essentially unsafe to resect from the optic chiasm.
Perfect. Just for the sake of time, what about the post-op endocrinological function? Yes, before we move to the next case.
The patient, I'll let Julia go ahead.
In regards, it's hard to say because I mean, the only thing I would like to mention, she did develop DI on the day, and I think on the day 2 post-op, and she did require DDVP like 1 dose, and then she actually did pretty good. And DI resolved on the discharge. She was doing, you know, like fine. It's hard for me to say in regards to her pituitary axis. We're gonna have a lapse, you know, like coming soon, but she did, you know, like the discharge on dexamethasone because, you know, like per neurology. That's why I think we'll see.
Absolutely. Thank you so much, Julia. Appreciate it. Maybe because the next case is a craniopharyngioma, if everyone agrees, maybe we move forward so Lina has a chance to also show some of the cases in pearls, and we can discuss a bit more about the pathology at the end if everybody agrees. Thank you, Krishna. Very nice presentation. Appreciate it.